levels as well. Other common difficulties that we'll probably encounter, erectile difficulties, particularly in younger males, and changes to intimacy. Women tend to be much better at managing changes to intimacy because the sexual drive is different. Males, because it's a very visible sign, having an erection, tend to cope less well. Unfortunately, Viagra is not a particularly good drug for these conditions because it tends to worsen postural hypotension. So dissuading GPs from prescribing Viagra can be a bit difficult because often the patient, if they've actually got to their GP, said, I'm having problems with erections, and the GP says, oh, have some Viagra, you'll end up with a patient who's got really no blood pressure when they've taken it. Inspiratory stridor can be problematic, usually in MSA more commonly, and about 30% will actually develop inspiratory stridor, usually manageable. Only on one very rare occasion did I see a patient end up with a tracheostomy tube, and I think the consensus of the team who ended up looking after him that was probably an inappropriate intervention anyway. So again, getting people to see the right physicians if they've got inspiratory stridor is actually very, very important. Blepharospasm, which is a squint, often treated very, very effectively with some selective injections of Botox. Again, that commonly occurs in MSA and CBD. And in PSP, we have to be very aware of the patient's direction of gaze, that they have got really limited movement of their eyes, which is often really good, easy to manage at home because you're in a home setting. It doesn't matter if things go a bit lower or sort of a bit middle level of the room. Hospitals, we're great. We put all the TVs on the ceiling these days. So when people go into hospital, often they're in a bed for a long period of time with not many people coming near them. Be aware they get really bored. Because they can't watch the TV to actually sort of take away some of the hours because it's stuck on the ceiling. And it's even more frustrating if it's switched on and you can't see it. So sometimes we need to break OH&S guidelines and actually pop a TV at someone's eye line. And be aware that even if we're setting up for reading or anything like that, it needs to sit within their eye line. And when we communicate with them, we might need to not, instead of standing, we might need to actually sit down at the bedside. And sort of so that someone can actually visualise us rather than actually sort of just hear a voice and see a bit of a body. And just to very quickly pull it together because we're running a little bit over time, this is actually a fellow that I looked after when I was a Parkinson's nurse in the UK. And he was actually referred to me by a local nursing home. He'd been admitted to the nursing home following falls in the community. His family lived at some distance from him. And he had a Parkinson's disease diagnosis, which he'd had for about 3 years. He lived on his own, so it was a very quick transition from community, hospital, nursing home, because they couldn't discharge him. He didn't have any care or support. The nursing home noted that he was a bit increasing in needs, but they didn't know him that well. They thought maybe this was just him when he came in. He had some episodes of fainting. Again, they didn't think too much of it. And unfortunately hadn't even thought to do a blood pressure. When you looked at his charting, we noticed there was worsening mobility. His Barthel scores were going off and his ADL scores were going off. And his swallow, people sort of said, oh, look, sometimes he chokes a fair bit. And we've started thickening his fluids anyway because we think that's what we needed to do. It made it easier. And the LMO who looked after the nursing home sort of thought, I think his deterioration is a bit rapid. I'm not quite sure what's going on, but hadn't got around to doing anything about it. So when I got there, I thought, actually, he's actually got quite diffuse bilateral illness. It's not dominant on any one side. And if it was just true Parkinson's, you'd expect to see symptoms more on one side than the other. Had some facial grimacing, and that sort of really classic sort of grimacing, right down to the point where he's having episodes of blepharospasm where he was actually sort of developing a real squint and not being able to see out of one eye. He was very stiff from a muscular perspective, really stiff, and had limited range of motion, and was not getting much bang from his Parkinson's meds when he took them. And in fact, all they were probably really doing was actually just lowering his blood pressure. Had some problems with urinary retention and really bad constipation. Had a bowel pattern where he would maybe move his bowels once every 7 to 10 days. And that was usually when they'd given him a sort of a bucket load full of Aperients. And he had some swallowing and pulling of secretions and really was clearly in need of a speech pathology review. So certainly from what I thought, I think it's probably MSA. Got him into the neurology clinic and they thought, yeah, probably MSA as well. We contacted the family and sort of said, can you please travel up to see us? We've actually got some information we need to pass on. And so we spoke to him and his family in a family meeting type setting to actually revise the diagnosis. Very aware that he was a man who was quite isolated. He didn't have family support, and we wanted, when he heard the news, that he actually wanted to be supported. We reduced his levodopa. We thought he was still getting some impact from it. He didn't want to stop it completely, so we reduced it, which minimised some of the blood pressure regulation difficulties. And we referred to speech, probably as our primary therapist, and then quickly, soon after, onto physio and OT. And seeing that the speech therapist worked really closely to actually change his diet and GAPA secretion management plan, which he then communicated with all the nursing staff, which was important. But then actually watching speech and OT and physio work together to get this man's seating regime sorted out. And we worked at the optimum position we could actually get him on his tilt and space wheelchair with a sort of a slight flex back of the back and the wedging that we needed to use to optimise his swallow, but also at the same time to keep him comfortable and keep him well positioned within the chair. Considering he had lots of stiffness, we also lose lots of wedges and some splinting as well. So we worked quite closely together. My role as a nurse was very much to, okay, I'll let you guys do what you need to do, but you need to show me, because I need to keep reinforcing it with the nursing staff in the nursing home. I worked on continence, and we developed a bowel regime, which was some oral aperient, but also some PR aperient once, sort of 3 times a week, which unfortunately we were at a stage where we really needed. And we discussed this gentleman's advanced care planning. He made decisions that he wouldn't have a peg tube, and that he would be happy to struggle on with what he was doing. And I then actually had to find a little bit of extra funding for ongoing speech pathology in the nursing home, because the nursing homes were funded for a limited amount of speech path, but not a great deal. So because that became an ongoing issue where we had to look at some very highly specialised swallow management plans. Fortunately, in the UK, the palliative care services are more than happy to actually accept people with non-cancer diagnoses. So we're able to actually refer them to the domiciliary palliative care service, who would be able to provide at least a weekly support visit to the nursing home, which we actually managed to actually facilitate and do. And ultimately what happened is that in a few weeks, well actually a couple of months after we'd put a lot of this in place, we kept up doing what we were doing, and he did start to develop chest infection. And he had one particular chest infection, which we decided, okay, let's just palliate him with this one. It's going to become overwhelming. So instead of antibiotics, we treated the gentleman with some sedation and some morphine to ease the respiratory stridor and manage that particularly well. And he actually had a very peaceful passing in his nursing home amongst the staff who'd become familiar with him, which was particularly important for the staff as well, because it's a bit of a journey for your staff, thinking that you've got one diagnosis and you're expecting this patient will live for 2 or 3 years, then we revise it and you've sort of, within 6 months, you've actually had a patient who's passed away. And that's all I've got to say for today.